And this is the presentation, but before it, I will introduce Melese. He is a midwifery specialist and public health researcher with a PhD in public health from Hawassa University. He began his career as a midwifery instructor and later served as head of the department at Hawassa University before pursuing his PhD. He has also held key roles, such as chair of the Institutional Review Board and various standing committees contributing to ethical oversight and research governance. Melese's research focuses on maternal and newborn health, family planning, and pelvic organ prolapse, supported by grants from organizations like the Laerdal Foundation, Worldwide Fistula Fund, and the universities of Minnesota and Michigan, right? He has published extensively on topics such as labor pain management, teenage pregnancy, and respectful family planning services with over 400 citations and H-index of 10. Wow, wonderful. In addition to his academic contributions, Melese has trained over 200 midwives in basic emergency obstetric care, family planning, and health response to gender-based violence. He is also a member of the Research Advisory Committee at Ethiopia's Ministry of Health, reflecting his influence in shaping national health policies. His career exemplifies a dynamic blend of clinical expertise, research leadership, and capacity building in maternal and reproductive health. So, hello Melese, are you ready for the presentation?
Yes, I can.
Okay, I will try to give you the remote control now.
Okay, thank you.
Oh, sorry.
I think I will share my own.
Oh, so your own? Okay. I will stop share first. Okay, now it's your turn.
Okay. Is this one visible?
Yes, I can see it.
Okay.
Okay. Would you mind make it wider or full screen?
Is this one better?
Okay, this is better for me. Okay, here you go.
Okay, thank you, Indri, and you all for coming. And this is about effect of midwifery-led pelvic floor muscle training on prolapse symptom and the quality of life among the women with pelvic organ prolapse in Ethiopia. And this was a cluster randomized controlled trial, and it was intentionally prepared to check whether task shifting can work or not. So this is a primary study actually. So, and I'm Melese, and there are co-authors of this research project. Dr. Rahel Nardos from Minnesota University, Dr. Binyam Sarak from Hamlin Fistula, Addis Ababa, Dr. Wandosan and Dr. Ayalo are from Hawassa University, and Professor Teresa was also from USA, from Worldwide Fistula Fund. So this is also done with the team of experts, and the presentation outlines will highlight on the background, the objective of the research, methods and the materials used in this study, and I will highlight the results and the conclusions. So by its definition, when you say pelvic organ prolapse, it is about a descent or a downward movement of the vaginal compartments and that is surrounding organs, including the uterus, the bladder, the rectum, and even sometimes the intestines will involve. And in normal case, these structures are supported by the levator animacies and the connective tissues. So that if there is any direct damage to this levator muscle, or if there is any damage to their nerve supply or blood supply, there will be weakening of this levator muscle. So the vaginal compartment and the surrounding organs will downward. And these are usually caused with different factors. And so far, the treatments are either surgical intervention or conservative management are there. And among the conservative management is one of the best and the first line recommended conservative management is pelvic floor muscle training. And this is recommended by different guidelines. Till now, it is recommended as the first line by the existing evidences. And the problem is that even though it is recommended as a first line, the awareness about this technique, how it works, and the benefit of this technique is poorly understood both by the women and even the healthcare professionals. And there are evidences from developed countries that shows this awareness is poor. And from low resource settings, including Ethiopia, there is no evidence, or the existing evidences are very limited, so that we can't say whether it is effective or not in low resource settings. And what the guidelines recommend is that this pelvic floor muscle training is best and that is most effective if it is provided by pelvic physiotherapists. As you know, these pelvic physiotherapists or even urogynecologists are not available in low-income settings like Ethiopia and others. So it is mandatory to have other mode of delivery or other model how to deliver these techniques. So we think about task shifting. That means where there is shortage of these pelvic physiotherapists, this intervention can be delivered by accessible healthcare professionals who are accessible in remote and low resource settings. That is why we selected midwives to test whether they can effectively deliver this training or not. And as you know, in Ethiopia, there are shortage of urogynecologists, and even regarding the treatment of this pelvic muscle training, there is no clearly stated management strategies. There are managements that are done at hospitals, and they are up to the gynecologists, but there is no clearly stated guidelines how to manage this disorder. But the problem is common, and even the government will accept that it is most common. So our objective was that it was to assess the effect of midwife-led pelvic floor muscle training on prolapse symptom and prolapse-related quality of life among women with mild to moderate pelvic organ prolapse. Mild to moderate pelvic organ prolapse means prolapse with stage 1 to 3 we mean. So what we did was that the Hawassa University, where I'm working now, has held in the demographic survey sites and in the southern part of Ethiopia. So that we did this study in that specific areas because we have other background data that can support our evidence. So we did a community-based parallel groups to arm cluster randomized control trials because of for the feasibility of the intervention and for the resource utilization, we prefer the cluster randomized control trials. So we involved women who were 18 years or more older and who have pelvic organ prolapse confirmed with physical examination. So from the interventional clusters, we have around 86 eligible women were recruited and around 101 women from the control groups were involved. So this randomization of the clusters, the health and demographic survey sites were randomized by non-research members who are staff of health and demographic survey sites. So they simply randomized the health and demographic survey clusters into intervention and control group simply by a simple random sampling. Then we recruited individuals from Hamlin Fistula Center who will perform a pelvic examination and identify eligible women. Eligible women in this case means women who have prolapse stage 1 to 3 and who have a symptom of prolapse based on the prolapse symptom identifications. I will describe it later on. Then these both are blinded to the intervention classification of one another. That means those who recruited the study participants were blinded about the cluster randomization. And those who randomized the clusters were also blinded about who will be recruited. So this is how we try to improve the quality of the data. And finally, after the intervention, the outcome was assessed by another third person who were also blinded about randomization of the clusters. These are nurses actually, but they are unaware of the cluster randomization, who are in the intervention and who are in the control groups. So What we measured at the end was that we measured the difference or the change in prolapse symptom before the intervention, after the intervention for both groups, and we compared that one. That is what we call difference in mean change. Because there is a change in the intervention group from baseline to end line. Again, there will be a change in the control group also from baseline to the end line. And then what we did was that we compared the change. That is what we call the difference in mean change. And these prolapse symptoms were measured by tools that were previously translated into the local language, and they have already published it previously. And the second outcome is the difference in mean change and prolapse-related quality of life. Prolapse-related quality of life are a measure of quality of life that are specific to the prolapse, so that it has around 20 items and 3 domains that measure physical domain, psychological domain, and personal relationships. And this tool was also previously translated and validated in Amharic language in Ethiopia. So to highlight what was the intervention, and the intervention group, what we did was that we trained midwives, and these midwives will provide the training at health center. Then the women will get that counseling at health center, and they will go back to their home and they practice this in the pelvic floor muscle trainings daily at their home. Actually, they do it 3 times per day. And what they do is that they simply contract their pelvic muscles. That involves 10 long contractions and 10 short contractions. These are repeated 3 times per day, in the morning, in the afternoon, and in the evening. And there is a follow-up, monthly follow-up at health center. They will come to health center, and the midwives will check whether they adhere to this training protocol or not. Then an update will be given for them. So this was continued for 15 weeks. Then after 15 weeks, there was no follow-up, but we counseled them simply to continue exercising this pelvic muscle training. And then at the end of the 6 months, we measured their prolapse symptom and their quality of life. And this 6 months was recommended because women can check or can feel the change in their prolapse symptoms after 6 months. And this was what was recommended by different literatures. So we used the duration of 6 months to allow women to whether they can feel it or not. And this is what was given for the intervention group. But both for the intervention, the control group, we provided lifestyle modification. This lifestyle modification counseling will be focused on bowel health, what they can do if they have bowel problems like constipation, for example, how to prevent that constipation. And the same true for bladder health, how to urinate and how to sit during urination, and what to do if they have some problems related with urination, and how to lift heavy things. Usually in Ethiopia, women are allowed to do heavy lifting works, so that we counsel, we measured that aspect. And we counseled them to how to lift a heavy weight. And again, we assessed in the counsel them on chronic medical conditions, what to do if they have chronic medical conditions like constipation, like chronic cough, and even if they have diabetes mellitus and others that can increase intra-abdominal pressure. So the lifestyle counseling was more focused on these aspects. And then finally, after the intervention, after 6 months of the intervention, we analyzed the data. And that data analysis was employed mixed effects generalized linear model. And we used complex data sampling analysis because we used a complex sampling at the time of sampling, so that at the time of analysis, we consider that one. That means we weighted our data for the cluster, the strata, and for sampling weights. So because we are expecting different changes, that means we expect a change in quality of life, that means 3 domains, so that it is a must to adjust our significance level based on the recommendation of bone foreign formulas. So our level of significance was adjusted to p-value of less than 0.0125. That means our confidence level is increased to 99%. That means, because we are expecting 4 different outcomes from a single intervention. That is why we adjusted this significance level. And finally, we received an ethical clearance from Hawassa University, and consent was taken from the study participants. So, and this study area, we do have 8 clusters, and we randomized 4 per each arm, 4 into intervention and 4 to the control arm. And a total of 186 eligible women were involved. In the intervention group, we do have 86 women and 101 from the control areas. And unfortunately, all of them have completed this follow-up in our case, and there was no loss to follow-up. And at baseline, the prolapse symptom and the prolapse quality of life are almost balanced. There is no significant difference at the beginning. So, but after 6 months of the intervention, we observed a significant change, both in prolapse symptom and in prolapse quality of life. Okay? So the second line here, and the intervention group, the change in prolapse symptom was observed for 5 points. And in the control group, only 1 point change was observed. So the difference from 5 to 1 was 4 points. Okay? So we observed a mean change difference of 4 points in the intervention group as compared to the control group. That indicates the intervention works in improving the prolapse symptom. And this is measured out of 28 points. So we observed a difference of 4 points. And in the quality of life aspects, we do have physical domain, personal domain, and the psychological domain. Almost in all the domains, there is a difference of almost 10 points in prolapse quality of life domains. So this, again, this indicates this intervention has significantly improved the prolapse quality of life. Moreover, we simply asked them for how they feel about this change after they started the intervention. That means perceived improvement on their self-response. So in the intervention group, almost 83% of them reported that their condition is better after the intervention. But this was already only reported by 41 groups, 41% in the control groups. On the other hand, only 4 of those who were involved in the intervention group reported that their condition became worse after the intervention. But this is around 26% in the control group. This indicates those who were involved in the intervention group have more better outcomes, while the condition more worsen in the control group. And the p-value was also significant on the crosstab for these specific interventions. So what does this finding indicate? I think it shows that the benefit of pelvic floor muscle training.
Hello, Melese?
I think he might have been thrown out. Let's give him a minute to come back, shall we?
Okay, okay.
I know his connection was a little bit unstable this morning.
Oh,
A little bit of patience, eh?
ah,
Is anybody else doing their pelvic floor exercises while they're sitting here listening to him? Because I am.
okay. Hello, Melese. He's joining again.
Good, good.
May I help you, Melese, for sharing your slides? You still mute your voice.
Is that visible, Indri?
Okay. Yeah. It's okay now. You can continue your presentation.
Okay, thank you. Sorry for the interruption. So what this finding indicates is that this pelvic floor muscle training delivered by midwives can improve prolapse symptom and the quality of prolapse-related quality of life. And this finding is supported by a previous multi-center randomized control trials conducted both in England and other Western countries. So the added value of this presentation or this finding is that this will extend the previous recommendations to low-income settings. So this intervention can work both in high-income and also in low-income countries. And the other advantage or the other important finding of this result shows that the observed mean difference is around 4 points in our case. Professor Susan Hagen has previously recommended that any intervention that can improve prolapse symptom by 1.5 or more points is considered as clinically important. So here our finding is more higher than this point. So we can conclude that our finding is both statistically significant and it is also clinically important. This is what was the advantage. And that's the second important point is that in pelvic organ prolapse, one of the most common indication for surgery is a feeling of something passing through vagina. Okay? A woman's feeling of something passing through the vagina was the most important indication for treatment. And again, it was considered as a crucial treatment outcome. In our setup, this symptom was significantly improved. So that still, it indicates that our intervention has a clinical important for both for the practice and for public policies. So this study has indicated that it has both clinical and statistical significant findings, but it has its own limitations. One of the limitations is that most of the measurements are based on patient self-response, so that the patient self-response may have some bias, especially what we call social desirability bias are there. That is the drawback. And the second one is we measured its effect only in the first 6 months, and we don't know the long-term impact of this intervention. So our finding is limited to short-term period. And these are the limitations of the study. And in conclusion, we can say that pelvic floor muscle training plus lifestyle counseling can significantly improve prolapse symptoms and the prolapse quality of life. And secondly, we can conclude that in settings where there are no pelvic physiotherapists or where there is no trained urogynecologists, primary healthcare providers like midwives, nurses, and others can deliver pelvic floor muscle training if they got adequate training for orientation. And these are our main conclusions. And as a recommendation, actually my recommendation is limited to Ethiopian context. So in Ethiopian context, there is no pelvic floor muscle training was not integrated into the existing health services. So our recommendation is that it is beneficial if the policymakers can integrate this pelvic floor muscle training into the existing maternal and reproductive health services. Again, primary health care providers need an awareness creation workshops so that they can effectively deliver this pelvic floor muscle training. And for further studies, I will recommend to measure some objective measurements in which we have simply based on patient self-responses. So we recommend further studies to measure it objectively and to measure the long-term effect of this intervention. Thank you all. These are our recommendations. I would like to thank the study participants, data collectors, and the Hamlin Fistula Center who were managed those cases who were with advanced stage of prolapses, and you all also for inviting us to this interesting presentation. Thank you.
Okay, thank you so much, Melese, for the presentation. Wow, it's very wonderful that you have RCT in midwifery research. Okay, the next session is discussion. So maybe some participants here have questions to you, Melese. Is there anyone? Okay, Mutiara. Mutiara said, thank you so much for the nice presentation. I have one question. Why did you choose RCT as your method? Why not quasi experiment? Okay, Melese, would you answer now?
Yeah, this was if there is no other. Okay, thank you very much. As you know, an RCT is the strongest type of research and generating the evidence. We can use quasi, but it is not as strong as the RCT because here we have a control group, so that we can sure that if you have a control group, we can be sure that the outcome or the observed effect is due to the intervention. But in case of quasi-experimental, we may not be sure that the outcome may be due to simply self-response because you know, this is a very sensitive issue. So it can be affected by others, like even self-responsibility itself can affect it, or there may be other factors maybe there. So comparing the quasi experimental to RCT, in the RCT you have control group, so that will ensure the observed outcome is simply related to the intervention. Thank you.
Okay, thank you, Melese. And how about other participants? Okay. Linda said, I have been doing my exercises throughout the presentation. How long do you recommend postnatal women should continue the exercises?
Thank you very much. Actually, the literature recommends this one, but that is slightly out of our scope because we work on treatment, not on prevention. So we included those who have already developed the case, and we trained them whether this training can improve the symptom or not. But what is recommended at postnatal is it is for prevention purpose, so that there are findings that support it can work, but it is not in our it is not from our finding. Thank
you. Thank you, Melese. Sorry, I didn't pick that up. Too early in the morning for me.
Okay, Linda. I just knew about this a kind of intervention for the woman to prevent the uterus prolapse.
Yes, as a prevention, yeah, it is recommended. Actually, the different literatures recommend that, and probably that will be our next project. And we are on team building currently, but we prioritize the treatment in our case because there are a lot of women, and we did this intervention in the rural area where healthcare seeking is very poor, so that we focused on treatment, not on prevention so far. And prevention is also important, and that will be the project of other researchers, or we will do it in the near coming.
Okay, thank you, Melese. We have one more question from Sheila. Questions about the intervention one. Were lifestyle factors applied to each arm or just the control? 2. How easy was it for the women to learn the exercises? Okay. Sheila has 2 questions. First, were lifestyle factors applied to each arm or just the control? And second question, how easy was it for the women to learn the exercises?
Okay. Thank you very much. This is the lifestyle counseling was given for both groups because it is important. It is an intervention by itself, and it is a recommended treatment and also for prevention. So we did it for provided it for both groups. Regarding the difficulty of providing this training, actually it was difficult, especially for those who have no formal education, and that was a lot of challenges are there. That is, if by the way, that is why we selected midwives who are working at primary healthcare settings, because they know the level of understanding of the rural women, so that they are trying to explain it in a way that they can understand, in a way that uneducated women can understand. Otherwise, it was somewhat difficult, and that was why we repeated the counseling 4 times monthly. Unless you repeat it frequently, it is difficult. And actually, there are challenges at the beginning, but later on, they will come to the track, and that is how we proceed. Did I address it?
Okay, I think there is problem with your connection, but I will repeat your answer. Okay, Melese. So first answer for the question, lifestyle applied both for the control group and the intervention group. And the answer for second question, it's not easy to explain to the rural woman about the exercises, right? But you try to give them education more frequently, about 4 times a month, so they can understand and they can do the exercises, right?
Yes, yes. One point that I would like to highlight is that explaining this procedure is better provided by health professionals who are working at a low level of health facilities rather than those who have specialists. Because those who work at a low level can understand and they know how illiterate women can understand. So we recommend that one even.
Okay, thank you, Melese. You have other question here. From Rizka Satyani from Indonesia. Hi, I'm also Indonesian. What are the potential challenges and ethical considerations in scaling up this intervention nationally, and how can they be addressed to ensure both effectiveness and equity in care delivery?
Okay. Okay. Thank you. This is also one important point. Actually, regarding ethical issue, what we did was that we do have a fistula center and the nearby at the nearby town, so that when we get an individuals who were in stage 4, we linked them to that fistula center so that women can be treated free of treatment. If you can have such areas, that will be easy ethically. But if you have no site who can manage those who are in the advanced stage of prolapse, that will be difficult. That will be because you already diagnosed them, then you can't leave them alone. So that you need to do something. And so by chance, we do have a fistula center in our study area, so that we are directly linked them to the fistula center, so they are treated there. And even after intervention, there are women who reported that their condition was not improved. So that again, we linked these individuals also to that fistula center. Then they are managed there. There is no payment. So they can be visited by urogynecologists and they are managed at there. And so ethically, that was one challenging part, but unfortunately we do have the setting, so we solved that. Regarding equity, that is why we took this intervention into primary healthcare settings and provided the intervention by primary healthcare providers. The problem is that in Ethiopian context, it is recommended to manage every prolapse at general hospital, which is not feasible for women who are living in the rural areas. That was the problem of equity, and the problem of accessibility are there. So that is why what we tested. So it is possible to provide this intervention at lower level health facilities by lower level healthcare professionals. We use the midwives who have a bachelor degree. So if they are awarded for 3 to 4 days of a workshop or a sort of training, they can effectively provide the counseling so that it can be effective and it can be accessible at lower level health facility. That is what we tried to do here. Okay, thank you.
Okay, thank you, Melese. Is it clear, Rizka Satyani? Say that question collected by self-report, right? So if the patient say that they feel better, it means that the intervention is effective.
Yeah. What we need to do is that we need to effectively train that midwives so that they can do it. It is not as such difficult. The training should be supported with theory, models, and videos. That is how we train the midwives first. Thank you.
Okay, thank you so much, Melese, and the participants who has a question and make this discussion more feel alive. And a great piece of research and presentation. Thank you, Melese. Oh, thank you, Linda.
Thank you all.